Dr. Shalvaree Vaidya is a health economist and life sciences professional with expertise in research, policy, and market access. She focuses on translating data into actionable insights to support sustainable and equitable healthcare solutions. Her work spans health policy, rare diseases, and stakeholder engagement to drive evidence-based decision-making.
Good morning, good afternoon, good evening. It's a pleasure to be here. My name is Shalvaree Vaidya. I'm a health economist and researcher with a background in pharma and consulting. As part of my academic and professional career, I've published several papers in health systems and rare disease topics. And as such, I'm here to talk to you today about a critical issue at the intersection of healthcare economics, innovation, access. And that's adaptive reimbursement strategies for rare disease treatments. So we all know that rare diseases really pose a unique challenge. There are over 7,000 rare diseases that have been identified, yet only about 5% have any kind of approved treatment. These conditions not only impact patients medically, but they also pose a very significant psychosocial and economic burden on families and caregivers. The misdiagnosis rate is also quite high within this population, as is the average time to diagnosis. And these factors really lead to an overall decreased well-being and decreased quality of life. So a few decades ago, because of this high unmet need in rare diseases, governments introduced special incentives to encourage R&D investment by pharma companies in these type of orphan drugs for rare diseases. And these policies worked, and it led to hundreds of new treatments. However, these treatments also came with a very steep cost. So many orphan drugs carry extremely high price tags. For example, the median launch price in the US currently is exceeding $200,000 per year. And actually, rare disease drugs have become a very profitable endeavor for pharma companies because of the specialized incentives that they get, like exclusivity, regulatory support, tax incentives, and strong financial returns and high margins. And this has resulted in several blockbusters that have brought in billions, which was not at all the original intent of these policies. So now we come to the central question. On the current trajectory that we're on, this innovation comes at a very high price, and it's very unsustainable in the long run because of the significant economic burden it places on health systems. And with that in mind, our discussion today focuses on how can we ensure access to life-changing treatments without overwhelming healthcare budgets. So traditionally, pricing and reimbursement frameworks don't really work well for rare disease treatments because they are designed for very common diseases with very large patient populations in competitive markets and with really well-established cost effectiveness benchmarks. Rare disease drugs or orphan drugs don't really fit this model, and that's for several reasons. One, the small patient population means that pharma companies can't really rely on very high sales volumes to recover their cost. So the price is set extremely high right off the gate. Second, a traditional cost effectiveness analysis using something like cost per quality, which is used to decide if a drug is considered worth it to pay for, that doesn't really work well with orphan drugs because it doesn't take into account the very small population, which then leads to very high costs per patient. It also doesn't take into account how life-changing small improvements can be for rare disease patients. Things like caregiver quality and how that's impacted. And also the fact that clinical trials for these diseases have very small sample sizes and very limited data. So basically, even if an orphan drug is really life-changing, it looks not worth it according to these traditional formulas. So many drugs end up being either rejected or delayed. And All this to say that using these traditional methods means that payers struggle to absorb the financial impact. And in the end, it's the patients that end up facing barriers to access. So, this is where adaptive reimbursement strategies come in. Adaptive reimbursement is basically any kind of flexible, data-informed payment approach for novel therapies. And it incorporates risk sharing, outcome monitoring, and non-traditional pricing to really ensure both innovation, but also affordability. So instead of applying a one-size-fits-all pricing and reimbursement model, adaptive reimbursement really aligns drug prices with their real-world impact. And this in turn allows for more flexible and sustainable payment structures. And these agreements require defining measurable outcome targets like survival and functional improvement so that we can then track patients over time. And the metrics that really matter for rare disease evaluations are things like real-world data and evidence, which can include survival rates and disease progression in real-world settings, hospitalization rates, ER visits, healthcare resource utilization, patient-reported outcomes like functional improvements, symptom reduction, and there's also societal impact metrics like impact on caregivers, ability to work and participate in society, reduction in long-term disability and social care dependency. The unmet medical need can look into disease severity and availability of alternative treatments. And of course, there are economic considerations as well. And the multi-criteria decision analysis is a tool that can then bring together all these factors to guide reimbursement decisions. And here's just some examples of what this can look like in the real world. So here are some approaches for adaptive reimbursement and pricing, something like value-based pricing, where prices are tied to health impact, patient needs, severity. There's paying for results, so payers would only pay if the drug works. Installment-based payments, so instead of paying this kind of exorbitant one-time cost at the beginning of the treatment, payers can then just pay over time and annuity payments. And you can even put this together with the pay for results, so you have these broken up payments, but also the payments stop if the drug stops working over time. There's also public-private partnerships, so governments, pharma, insurers that can co-fund some of these R&D costs so that it can lower the financial burden for everyone involved. There are subscription models, so things like a Netflix for drugs, which is, governments can pay a fixed price for unlimited access to a specific treatment option in a disease drug. And there are many, many others, managed entry agreements, hybrid models, and no two contracts look alike or need to look alike. So implementing adaptive reimbursement and innovative pricing for orphan drugs can really create this kind of win-win-win for all the major stakeholders involved. For health systems and payers, adaptive models really improve cost control and sustainability at the system level. So by capping the expenditures or paying only for successful outcomes, public healthcare programs can really better manage limited budgets. And for example, performance-based deals, right, can allow patient access to innovative medicines, but also while controlling waste and aligning the healthcare goals with innovation and equity. Budget impact then becomes a lot more predictable. So a subscription model or a population-based cap, for instance, that sets a really known spending limit for rare disease programs. And this can really enable effective budget allocation and planning for national health services. Over time, the real-world data collected can also guide which treatments really offer value. So we ensure that, our scarce resources are allocated to the most high-impact therapies. And, in short, health systems really gain a tool set to contain the costs and improve long-term sustainability without just denying access to expensive drugs. And this goes for insurers as well, right? So adaptive reimbursement, primarily, it's trying to mitigate the financial risk. And so a high cost orphan drug that can really threaten an insurer's annual budget. It can give this kind of very sudden budget shock, and something like $1 million therapy can almost bankrupt a small insurer plan, right? So by distributing the payments over years and pooling the risks, so tools like annuity payments and outcome-based rebates, it really spreads out the risks, and then payers benefit by not having to pay this full price upfront, and especially if then the drug underdelivers later on. And this prevents wasting funds on ineffective treatments. So overall, we're trying to kind of improve value for money. And in that, this also forces pharma companies to identify the patients that are most likely to benefit. Because if the company's revenue is on the line for non-responders, then they're going to make sure that the individuals that get the drug are the ones that are going to respond to this particular treatment. For pharma companies, it might seem like right off the gate, why would they do this or why would they agree to something like this? It seems like a concession on their part, but actually it can accelerate market access and uptake of their new drugs. So manufacturers who agree to adaptive pricing, they may get their products covered by payers who maybe otherwise would be very hesitant to kind of cover something so expensive, right? So this means that more patients in the end would get on the therapy sooner, and there's a broader market for the pharma companies. And the companies themselves can also get a chance to demonstrate real world efficacy by partnering in outcomes tracking. They can prove that their drugs has value over time. And this could potentially also unlock future rewards. So bonus payments for really outstanding outcomes or expanded coverage. Innovative models can really provide also a very predictable revenue stream for pharma companies. So rather than uncertain usage, a subscription, for example, can guarantee a fixed payment over time. Same with annuity models that ensure that the company would still receive the full price, but of course, only if the drug works, but it's also just spaced out. And importantly, adaptive reimbursement strategies still maintain the incentives for these pharma companies to invest in R&D for orphan drugs. And by them showing this kind of willingness to share the risk, policymakers would then avoid really heavy-handed price control strategies and offer this collaborative solution. And pharma companies love collaboration, so this is good for them as well. And so overall, pharma companies get faster coverage, they get stable revenues, and very sustained innovation incentives through these models. So that can also enhance trust with payers and with the public. For patients, and patients are the most critical beneficiaries of these type of programs. Adaptive reimbursement frameworks are fundamentally, they're aimed at improving accessibility, getting life-saving treatments to patients who need them. And so when payers are more willing to cover an expensive orphan drug because the financial risks are managed, patients face fewer coverage denials and delays. And by balancing cost and reward, these frameworks really help keep the pipeline of rare disease drugs flowing. And the overall result is greater patient access to orphan drugs and potentially better health outcomes because as needed treatments reach those who were previously maybe priced out or unsupported by insurers, this can be a very good thing for patients. These are just the three of the examples that ways in which this has been used in real life. So outcome-based reimbursement, installment-based payments, and hybrid models. There's been money-back guarantees and payment at result contracts. There's other examples as well. So what's the holdup, right? Like, why haven't we fully shifted to adaptive reimbursement if it works so well? And that's for several reasons. So one is administrative complexity. So performance-based contracts require extensive tracking, data collection, enforcement mechanisms. There's also legal and regulatory barriers. So many insurers and national health systems are not structured to handle installment payments or outcome-based rebates. There's misaligned incentives. So pharma wants to keep the prices up and payers want to drive them down. So making an agreement can be difficult. There's also a lack of standardized real world data collection. Many health systems really lack the infrastructure to monitor patient outcomes over long periods of time. And this can make risk sharing contracts difficult to enforce. So, how do we make adaptive reimbursement strategies the default? We have to standardize these frameworks. So, right now, these models are negotiated case by case, and this creates administrative complexity. We need to establish clear guidelines on these frameworks so that we can adopt predefined contract templates for this kind of risk sharing. We also have to expand real world data infrastructure. Adaptive reimbursement really relies on real world data, and most healthcare systems really lack the infrastructure to collect and analyze it at a bigger scale. And we need to establish national, global rare disease registries so we can track these long-term treatment outcomes. We can invest in electronic health records, AI-powered analytics to streamline evidence generation so that we can really ensure that drug payments are linked to actual clinical performance. And we finally have to really align stakeholder incentives. Pharma companies really fear unpredictable revenues. Payers are worried about budget. Governments are also cautious about policy changes. So, incentivizing pharma participation by offering faster market access in exchange for this kind of flexible pricing, encouraging payers to adopt adaptive models by providing these type of financial safety nets and risk pooling mechanisms for high cost orphan drugs, we have to get all these stakeholders to the table. And by making these changes and leveraging data driven reimbursement frameworks, we can really ensure that rare disease treatments remain accessible and without compromising the financial health of our healthcare systems. Because now the shift towards adaptive reimbursement isn't just a theoretical solution, it's happening. We're in a transition period. It's a necessary evolution in how we will continue to pay for innovation for rare disease drugs and in a way where we can really safeguard our health systems into the future. Thank you so much for having me and for being here today.